Hello, everyone. This is Chadi Alraies from the Heart of the Matter. I'm really today privileged to have a unique and also a very close friend who has been a friend for many years since college time to talk about a new episode. This time, we're not going to talk about clinical science or clinical trial, but about health and weight management. This is a very hot topic. A lot of people kind of take the short route or the shortcut to how to lose weight. Or kind of follow a plan and eventually fall off quickly because the consistency is and the follow-up has not been there. So I'm really delighted to be with Dr. Aya Rifai. She practices internal medicine as well as obesity medicine in the Bloomfield area and the Metro Detroit of Michigan. She cares for patients in the outpatient setting in private practice. One of her main focuses is weight and obesity management. She practiced out of the Weight Loss Michigan providers various weight management solution, and she utilized a lot of tools to support patients during the weight loss journey, coupled with continued support after a patient with overweight or obesity reaching their goals and also their health goals. At Weight Loss of Michigan, evidence-based medicine, in addition to holistic options, are available and used to support patients in their weight management journey. Again, I'm really delighted to be with Dr. Rifai to kind of teach us tonight about all these delightful tools that we should learn about and how to utilize them in real day. Dr. Rifai, thanks for being with us.
Thank you, Dr. Reyes. I'm flattered and honored to be speaking to an esteemed audience, knowing who your audiences are. So thank you very much for hosting me.
Thank you. And also with our continuous host, Dr. Anisha Pareddy. She is the long-standing host for the series. She's going to be helping us moderating this topic, which is very important as well. So let me start with this big question. So what is the definition of obesity and overweight?
Okay, this is an excellent question. I did prepare a few slides to kind of explain a little bit about overweight and obesity. With that being said, definition of obesity is as follows. So obesity is a disease, right? So we think of it, okay, someone is big, someone is huge. However, overweight and obesity are both diseases, diagnosed and evaluated, managed. They're complex, they're chronic, typically don't go away. We use several tools to assess the patients in evaluating them, whether they have overweight or obesity. The main one that is used by medical institutions, by insurance companies, is the body mass index, BMI. It's a simple ratio between height and weight. Weight is per kilogram, height is meter square. So if a patient is underweight, is less than 18.5, I mean, you've got the values in front of you. Once we start worrying is when BMI reaches 25 and above. Then you start thinking about obesity. When BMI is 30 and above, then you classify it obesity class 1, class 2, class 3. However, this is for not all of the world population. This is strictly for Caucasian individuals. Once we're talking about Far Easterns, Indo-Pakis, African Americans, the ratios are different. So for the US population, we kind of use this also around the world, but once we're talking about other individuals, the ratios are different. We focus a lot in our office on waist circumference because this is the main indicator when it comes to the illnesses that are associated with overweight and obesity. So for men, for best health, we like the waist circumference to be less than 40 inches, for women less than 35 inches. And one main thing that is also important to give us an idea of what goes on in the body is the waist to hip ratio. So for women, it's less than 0.8. So again, smaller waist, wider hips. For men, less than 0.95. And once we also worry about this issue, we have to look at the risk factors of the diseases associated with obesity.
I mean, as soon as you mentioned these numbers, start looking at my waist and trying to do the ratio, because I never done this ratio before. This is a new definition I never learned before.
New definition. Yeah.
And the other thing that I was thinking about as well is that I lift weights, so I know that the BMI is not necessarily accurate for men and women who lift weights, have heavier muscle mass, because muscle weighs more than fat. So that was the other thing that I was thinking of. So Dr. Alraies, it seems like both of us were just categorizing for ourselves, right?
100%. It's not only a BMI and looking at a number. BMI doesn't really provide an accurate information of the illnesses that are going on in the body. I always tell my patients, I'd have 3 people that have the same BMI, and I typically throw the number like 31 or 32, which is like obesity class 1. And I would tell them, you have Sylvester Stallone, you have a sumo wrestler, and you have Rapunzel. They all have the same BMI. They all have BMI of 31 or 32. And I would tell them, which one would you think would be more in trouble of those 3 people? And some of them don't even know who Rapunzel is. And then maybe Dr. Alraies, or I will tell you, or for any of the audience, Rapunzel is the princess that lives in a high tower, and she's got really, really long hair, like very, very long hair. So her hair would weigh a lot, but her body's really thin and her waist is small. The sumo wrestler, the majority of his body mass is fat mass, and of course Sylvester Stallone's all muscle. So BMI doesn't really give us an idea. It gives us a broad idea, because how many of our general population are any of those 3 individuals, right? So those are the outliers. The general population, if I tell someone, if my medical assistant tells me someone's BMI is like 31, the likelihood of them struggling with weight issues is probably on the higher side.
Right. Yeah. I see this chart is very useful here to just looking about the prevalence of the disease and how much we have in that community.
Yes.
Let's go over that.
So for obesity prevalence in general in the US, it's about 44%, anticipated for 2030 to be about 50%. And then if you look between men and women and their ages, really women in the ages 40 to 59 have the highest rate, and this is strictly obesity, talking BMI 30 and above. Close to 50% of women struggle with obesity between the ages of 40 and 59. And so, of course, this is multifactorial, and this is based on BMI numbers. So you wonder in those numbers in the green with 60 and older, if the decrease in muscle mass and the shift in fat mass is also a contributing factor in that sudden decrease in percentages, right? So like there's also almost like a 10% prevalence in decreased in those populations. So you wonder, is it like a muscle mass that's involved? Because this is what tends to happen as we advance in age.
Dr. Rifai, I know that obviously you work in the greater Detroit area, which, means that we have a lot of South Asians, we have a lot of Middle Eastern folks. How would you say, just anecdotally, the prevalence of obesity within these patient populations compared to the demographics of the greater United States? And how do you feel like, because I'm sure it's different and you characterize it differently. And I think, I love talking with the general, but as a South Asian myself, I really appreciate having somebody who directly works with, my own population, right?
Yeah. So interestingly, us, Michigan, we are probably the top 5 winners of the U.S. when it comes to overweight and obesity. Unfortunately, Michigan is probably number 2 or 3, believe it or not. Colorado has the lowest rate of overweight and obesity. Then you have like Mississippi, Alabama, Tennessee, right? Kentucky, those folks really struggle with overweight and obesity. And then West Virginia a little bit, but Michigan is pretty up there. And then once we have like different population for Metro Detroit, as we are pretty diverse, it's across the board, everywhere. It's everywhere.
Yeah. What are the risk factors, Dr. Rifai?
So risk factors for overweight and obesity, really genetic is number one. You'll see it in families, and then married families, right? So if one spouse struggles with weight, somehow over the years that get transferred into the other spouse. So you'll see families that are on the thinner side, families that are not, and you wonder, is there like also a microbiome component that comes with this issue, right? Because now gut bacteria and healthy gut is the thing, and we know there's a direct link between our gut and our genetic composition and our weight as well. Psychological, depression, anxiety, using food as a source of comfort, behavioral. So, I got a great day at work today. I go out and celebrate with my friends. We eat and have desserts and drink, right? High caloric intake. I had a horrible day at work. Guess what? I seek out food for comfort. So again, a lot of our behavior, and of course, environmental, right? So our environment is really obesogenic in nature. So, just imagine when you guys go to work and you go to the doctor's lounge and you have like all of these snacks and bagels, and everything revolves around food, from Thanksgiving to Christmas to Valentine's Day, Sweetest Day. I mean, there's always something that we are celebrating right around food. And believe it or not, once all of these things happen, then you have like metabolic issues. Like the likelihood of someone having profound hypothyroidism as a reason for their challenges with weight is less likely in comparison to the other things that we've just talked about. Social, cultural, again, you see it in specific societies, more ethnic groups celebrate around food, do activities around food, and of course, once it comes knowing and empowering ourselves with information, so that's where the social culture also factors are involved as well.
And I was just wondering, again, we're working in the Detroit area. The other thoughts that I had about, or was wanting to ask about, was, environmental being, having access to healthy food, right? Because I know that,
Correct.
I know Greater Detroit is different than Metro Detroit, and
Correct.
Having access to food being a cause, and access to healthy, clean things that, that really, yes, that sustain us, that nourish us, rather than fast food that's cheaper and more readily available in Detroit. And then the other, thought that I think really sticks out to me is that Detroit being one of the last stops of the Underground Railroad from the Civil War, that means that there's a significant population that lives here that are descendants of people who were enslaved, and have a lot of epigenetic trauma and epigenetic factors that really just kind of continues to play a role. Just curious as to how you see that and address it in your practice.
100%. So yes, downtown Detroit individuals certainly struggle more with weight. When you look at food and as a source of wealth and independence, and having more and more and more food as a way to avoid famine, right? And being enslaved and being a little bit on the thicker side means that you are less likely to be struggling, right? And then yes, definitely having the resources for healthier food options. That's 100%.
Dr. Rifai, you mentioned something about, and also Dr. Pareddy also mentioned that, about the muscle and fat ratio, right?
Yes. So yeah.
So how do you calculate that?
So really, when we talk about overweight and obesity, just like Dr. Pareddy mentioned, it's muscle mass evaluation of our fat mass, because the whole issue is the adiposity. Excess fat mass in wrong places in the body. So those all will be directly related to glucose intolerance, insulin resistance, dyslipidemia, and cardiovascular disease, now that we're talking about heart health. So really, like when we talk about BMI, just knowing someone's BMI is never 100% an indicator what their health is going to be, because individuals with upper body fat accumulation, they typically have a higher visceral fat. And this is the main problem. So you'll see individuals with like thicker neck, like hump right around their shoulders, larger arms, larger bust, larger abdomen, and thinner legs. Like, you'll see them like legs that are like sticks, because everything is revolving right around the midsection of their body, the higher midsection of the body. So we have the subcutaneous fat, and we have the visceral fat. So the subcutaneous fat is certainly not as dangerous as visceral fat. So when you see individuals having fat in the lower section of their body, like below the waist, those will not have problem with insulin sensitivity as much as those that have the visceral fat. And that goes along with when we talked about the waist to hips ratio. So you'll see people with smaller waists, yes, larger hips, so their number is lower, so their risk for metabolic illness is much lower.
So how do you calculate that? So how do you calculate that, the ratio or the visceral mass versus sub-Q mass? Is there a way we can measure that?
Yeah. So in our office, we have scale. It's called the InBody. It's a body composition analysis. So this is an example of someone that we have. Actually, this is from the InBody website. So this individual, they weigh 183 pounds. Their skeletal muscle mass was 94 pounds, and their body fat mass was 18.7 pounds. It's a scale pretty advanced. You sometimes see it at certain gyms. Patient will stand on the scale barefoot. They will have like handles that they kind of like grip on, and then there will be a little electric current that goes through their body and calculates all of these numbers. The machine was able to calculate their BMI. Again, it's a ratio because you punch in like what their height is, but truly, knowing that, okay, they have 18 pounds in fat mass, I don't know what that means. So we really need to focus on their percent body fat, right? From this information, I can't tell you how tall this person is, but I can tell you that their percent body fat is in a good range, right? This person is really, really lean. This is someone probably that runs marathons.
So what is a good ratio?
What is a good ratio? So I know the slide is also smaller, but we typically kind of measure the patients pretty frequently as they are in their weight loss journey, especially now with those new medications that are out there, and some of them may affect skeletal muscle mass if the patient's not paying attention to what they're doing, what they're eating, and how much they're exercising. So we make sure that we see a trend and making sure that the patient is maintaining their muscle mass. So what would be a good ratio? This is a recommended kind of numbers for percent body fat. So between men and women, based on their ages, you know that as soon as the numbers go into the 30s, upper 30s, and the 40s and the 50s, of course, much less in men, then you know that they are getting into trouble. This is another scale that is out in the market. It's called Tanita. So you can get one of those scales at home if someone is really interested in understanding their body composition. That is something that's readily available. Of course, it's not going to give as much information as the ones that a person might get at a doctor's office that deals with obesity all the time. but it'll be enough information where the patient will be able to learn so much about their body.
What's
Perfect.
the role
So
of a DEXA scan in one of these?
So the DEXA scan is pretty advanced, and it gives way more information than this one, because it's a bigger machine that will provide kind of more comprehensive eval than this one, because it's also got a picture. So you'll see like where the fat distribution is. With the other reports, what you're seeing is numbers. With the DEXA scan, what you'll be seeing is like a picture of, okay, well, there's more fat in the belly, there's more fat in the arms, more fat in the legs. So that's a great question, actually.
we have very sophisticated moderators. I mean, I have no idea what this is.
I'm very
like
interested in all of
moderators.
this.
Yes.
It's a personal interest, but of course it's an academic interest. So it's a marriage of two of my favorite things, personal and academic, right?
Yeah.
Best combo.
Yeah. So where do we? So let's say a patient walks into the clinic. What is your protocol? What is your routine for evaluation and management?
Okay, so typically when a patient comes in, we get a pretty comprehensive history about them. So what they have tried throughout the years, during their weight loss journey. And of course, apart from the genetic component, we want to know how much they weighed when they were born, and what's their family situation like. What about their parents? What about their spouses, their best friends? How much they sleep, how much water they drink. I mean, we do get a pretty comprehensive evaluation for the patient. Of course, there is a slew of labs that we will be ordering, evaluate for fatty liver, kidney functions, of course, lipid panel, evaluate for sleep apnea, make sure their CBC is okay, high sensitivity CRP, insulin levels, A1C. So pretty comprehensive evaluation in the labs, because that will give us a good picture on what's going on with them. Because anytime you have someone that has overweight or obesity, any of these issues are directly linked to overweight and obesity. And you guys being in the heart health field, if you see like this section, the circulatory is probably the longest list. From high blood pressure to high cholesterol, of course, atherosclerosis, irregular heartbeat. For AFib, like obesity is one of the highest reasons. I mean, correct me if I'm wrong, right? Heart attack, heart failure, poor circulation, right? All of those are directly linked to heart disease, the number one killer, not only in the US, I mean, of course, worldwide. How many times I get notes from cardiologists all the time when they give out like recommendations in the assessment and plan. First thing, advise patient to lose weight. Always. Never fails.
And that's the toughest job, Dr. Rifai. Like, I am scared to gain weight because I don't want to say it and then practice what you preach, right? So
correct.
But it's tough balance. I mean, you are between your job, you have to fit in. That's, I think, where clinic comes into practice and how to keep us in shape.
Yes.
I also really just appreciate what you do, because the thing is that, we are, well, I hope to be, right, and even as an internal medicine doctor at this time, we are internal medicine specialists, but also not obesity specialists, right? We are Dr. Alraies is a heart specialist. He is a cardiologist, right? So we know the basic principles, but really to be able to follow it and really give our patients the resources that they really deserve to get a chance to truly lose weight and to really impact their health. I mean, we need people like you. We need more people like you that are accessible. And so I just want to just say that we really appreciate what you do, and you also just make it so approachable for patients, so there's not shame around it. Really, it's just for their betterment, because that really gets conflated a lot. So just wanted to say that
you guys save lives every single day, like in the true sense of that word, saving lives. However, we want more addressing the overweight and obesity. So that way, we take a little bit less of a burden on you. You'll get less calls for STEMIs at night.
That's exactly my point. Is it's an upstream problem. We fix the upstream problem. We shouldn't be having activation at night. The fact I tell the patient, the fact you showed up on the cath lab table, we failed as a healthcare provider.
Yes.
We failed you. We didn't give you the right medication, whether it's access, whether it's insurance coverage, whether it's medication, prevention, practice and prevention. We don't get sick. We don't see the doctor till we're sick. But your clinic is completely specialized in something we don't feel till it's too late.
Correct. Yeah. I mean, as soon as patients reach you guys, this did not happen the night before. It may have happened the night before in the sense of it, but it took decades in the building, right?
Absolutely.
So it's yeah. And then, the biggest thing that everybody's afraid of is actually cancer risk. There are at least 13 types of cancers documented that are related to overweight and obesity. So for female cancers, adipose tissue produces excess amounts of estrogens. And then you worry about high levels of insulin and insulin growth factor type 1. That's related to colon, kidney, prostate, endometrial cancers. And of course, leptin, when there's abundance amount of leptin, then there's aberrant cell proliferation, which is like, yes, that is what cancer does. And fat cells actually have direct and indirect effect on other growth and metabolic regulators. So that is one big thing that, of course, everybody's afraid of.
Absolutely. So, do you want to walk us just through how to the person kind of go who's running through obesity or overweight? What are the dilemmas or the confusion or the struggle they go through, especially with this day and age where the life and stressors are tremendously and kind of unpredictable?
Yeah. So, weight stigma is a huge thing. You'll see parents, family members, bullying big time, employers, and people may not be hired due to their size. Psychological effects, and a lot of them are not vocalized. So a person will be struggling with anxiety, depression. They will be seeking food. You have a lot of what you call like closet eating people. So they don't want to tell anyone. And our lifestyle and our food resources make it so easy. So drive through, a person would go to any of those fast food places. They would eat in their car and nobody would know at all. So there is a lot of weight bias that happens around us. And I see a lot of tears in the office, a lot of tears. Relationships, spouses that no longer have a good relationship between each other due to size, kids, and no one can find resources. So when we support our patients and make them understand that their struggles are real, that the weight is actually a disease, and we'll be able to help them manage that disease, then surprise, surprise, we'll get way better response versus kind of shaming them. Then we'll get way poor response with those patients. And I hear a lot of times, actually, patients tell me that doctors have shamed them. Like they would go to the doctor's office and the doctor would tell them, "Oh, you gained 20 pounds. What did you do?" And and then they will start blaming them for whatever has happened to that patient.
And the reality is, we actually don't. So sorry, Dr. Horvis, but we don't actually get much training to actually talk about diet. We don't actually get much training around obesity. We talk about it as a disease. We learn about it as a disease, but then society tells us something else. Society, it's so having both of these things of whatever our own concepts, whatever we walk into the room with. And then on top of that, in medical school, in the United States, we don't get, we talk about it maybe for 1 or 2 lectures, but we don't talk about how do we actually address this? How do we actually think about it as a disease rather than bringing our own concepts into the room? And how do we really treat our patients with respect? Because like you said, shame doesn't get us anywhere. And as doctors, I would, I don't want to speak for Dr. Alraies or me, but as a whole, there's not a lot of humility without, having a haphazard 5-minute talk where they end up getting shamed in the office and don't feel like coming back,
Correct.
Yeah. So go ahead, Dr. Alraies.
No, same thing. I mean, I told the patient is like healthy food is expensive.
Yeah.
Have cut out, but go ahead, Dr. Rifai.
Can you hear me now?
We can hear you.
Yeah, we can hear you.
Yes.
Yeah, I just want to always tell the patient the same thing in Metro Detroit. I tell them healthy food is expensive. It's just expensive. And it's funny, we have Whole Mart here, Whole Food next to the hospital. It's expensive.
Yeah. Yeah.
And the unique thing about the Whole Foods in Detroit is that it's still only one of the only grocery stores within a 10 or 15-minute radius. It is one of the most subsidized Whole Foods in the entire country, but it is still extremely expensive to come up with. But you can find a Cane's, you can find a McDonald's, you can find a Burger King. And the thing is food in the end of the day, but having time and access to all of this stuff is just difficult for our patients.
Yeah.
So
however, like Repatha or Lakeview are probably way more expensive than Whole Foods.
Exactly.
Right.
Exactly.
Being not able to go to work post a stent or post cabbage for 2-3 months is way more expensive.
Exactly. And even, we haven't even made it into our, having patients referred to you, that should be something that we do right away when we notice something, right? That
Correct.
should be having more obesity doctors, because we have an obesity, what we call as an epidemic, right? It's real. Yeah. And I don't mean that in the other sense, but the more people that are willing to address this kind of, even preventatively, the less that this becomes an issue for us as a whole, right?
Correct. And when we kind of go through evaluating the patient, it's really the 5 A's, and this is something that not necessarily you need to memorize like 100%, but always remember to ask permission when you want to talk about weight. It's something that we do so naturally that we're like, oh, Mr. Smith, I want to tell you about your weight. Your weight is this much, and we think you have challenges with your weight, so we are diagnosing you with obesity. Well, we start the conversation by, Mr. Smith, is it okay if we talk about your weight today? Right? So sometimes the patient may not be ready on that day. Believe me, there is no one that has a weight challenge that is unaware that they do. There are some, a very slim amount of individuals, but the majority of them do know that they have a weight issue. So asking permission to talk about it is essential in that process. And after we ask, if they say yes, if they say no, then you're like, okay, let's talk about your blood pressure. If they say yes, then we tell them, okay, well, based on your numbers, this is your BMI, this is your waist circumference, this is where we are in the obesity stage, and we worry about these medical issues and complications of the excess weight. And sometimes that's when things start to ding in their brain, and they would know, oh yeah, I gained 10, 15 pounds in the past year. And that's when my knee started to hurt. So arthritis is a complication of obesity. And then they would know that, okay, well, if they lost that much weight, then their knee would probably hurt less. And then we advise them that, okay, well, all we need is, okay, to start with a tiny bit. We need like 5 to 10% of your current body weight lost in order to have some of the metabolic issues improve. And this number, this magic number of 5% loss, is directly related to improvement of metabolic issues, specifically hypertension, hyperlipidemia, insulin resistance, and kind of elevated A1C, prediabetes. A mere 5% of body weight will produce that. And then we agree on typically on realistic goals. And we talk about, okay, we're not going to lose 150 pounds in 2 months so you can be in a bikini in Hawaii, right? So this is not realistic. We talk about the weight journey, what they're going to do, and aim for like maybe 2 pounds a week, if depending on, of course, what they're doing. And then we identify their barriers, like why they can't go to Whole Foods, right? What is the challenge? Is it too far? Maybe they can definitely finding barriers that are the challenge in their journey. And then if that's not something that we're willing to do, then we at least assist them of saying, okay, you know what, I can refer you to a dietitian. I can refer you to weight management clinic. There's so many tools and options that we can support our patients with. But it truly starts by asking permission.
I really love that. And I think that it's just very empowering because you're bringing them, we're along with the journey together rather than us, the kind of paternalistic idea of medicine of us telling our patients what to do, but really it's asking them, hey, can we do this together? And I think collaboration is honestly, it's how medicine has changed, right? In this day and age, and how I really think it really, it's really just it clearly shapes your practice really well. So
yeah. It's I like this paternalistic way of looking at our patients. Yeah, that we sometimes tend to do that. Yeah.
Can we move on, Dr. Rifai, to therapy?
Yeah. So therapy, typically, if we're gonna treat patients, really, we look at it as a chronic disease. We start by traditional lifestyle modifications. This is necessary no matter what we end up deciding on doing, even like bariatric surgery. We have to start with lifestyle modifications. This is food, this is physical activity, these are behaviors. If you want to consider pharmacological agents, and then if it's more severe, as we can go through afterwards, if we needed to do bariatric surgery, it's everything together. It's comprehensive. It's not one thing or the other, because believe it or not, patients tend to learn how to bypass some of the therapies that we tell them, and end up gaining a lot of weight afterwards. So if we look further, as soon as we see a patient's BMI reach 25, and of course 23 for Asians, then we have to recommend lifestyle modifications. Please start to pay attention to your diet, whether it's low caloric, low carbohydrates, quality fats, increased physical activity, planned physical activity. If they have a sit-down desk job, a lot of people do have that. We remind them, okay, well, you got to get up and start walking. We consider medications early on. If they have a BMI of 27 and above, with comorbidity. So you'd have someone BMI 27.1 and they have hypertension. Okay, well, in addition to lifestyle interventions, we really should consider some sort of medications. And of course, for the Asians is BMI 23 and above with comorbidity. So again, way, way lower. If I have someone of the Asian population and they have BMI of 24 with comorbidities, and I want to add to their treatment plan, in addition to their lifestyle stuff, some sort of anti-obesity medicine, our challenge that if we were to seek insurance coverage, it's not going to fly because that person's BMI is on the lower side. So that is another challenge that we deal with all the time, because now all of a sudden you have these different criteria that are applicable to patients, however, not identified by insurance companies. So this is kind of like a fine art, and you see, Asian population, they really struggle as soon as they gain a little bit of weight. So if their BMI is like 28, 29, they probably have like a lot more problems, because when do we consider surgery in those individuals? BMI 30 and above with comorbidities. For Caucasians, the rest of the population, it's BMI 35 and above with comorbidities. And of course, if it's 40 and above without comorbidities. And then for Asians, it's 35 and above without comorbidities. So you really, really have to introduce treatment early on for the majority of our patients. And then medications. When it comes to anti-obesity medicines, this is like a timeline of what's going on right now in 2025 and what has gone since 1933. You would see side effects of medicines, the reasons for their discontinuation, this beautiful rainbow pills, which was a mixture of amphetamine, a diuretic, I believe it was like chlorthalidone, and then like a thyroid medicine, so all in one pill. Of course, it led to anxiety and death, so it was discontinued. But it was used for like a good 25 years, right? And then, of course, the famous fen-phen. You guys are probably more familiar with that than I would be, right? Since it's got the majority of the problem that came with it are cardiac in nature. Orlistat used to be a prescription. Now it is over the counter. It is not really friendly from a side effect standpoint, because the patients would just have to like use the bathroom immediately after they eat anything fatty. So they would just like lose fat and stool. It's not very popular. And then lorcaserin has been discontinued, and this is not too long ago. It was discontinued in 2022 due to increased cancer risk. Qsymia, we use that a lot. It is phentermine and topiramate, and it works pretty well. A lot of times, if we were to get challenged with insurance coverage for Qsymia, then we would just prescribe phentermine and separate and Topamax separate. It's not going to be as amazingly effective and potent just because of the formulation of the medicine and absorption. Naltrexone and bupropion, which is Contrave, also widely used, works really well as well. Again, if it were to coverage issue, then we prescribe them separately. Liraglutide, that is Saxenda, also Victoza. It's a daily injectable GLP-1. I think it is going generic fairly soon. I think the patent just finished not too long ago. And then semaglutide, everybody's favorite these days. Ozempic is the anti-obesity medicine. Ozempic is the anti-diabetic medicine, and Wegovy is the anti-obesity medicine. Of course, this is all over the news. All the famous actors and actresses, this is what they do all the time. And the newest kid on the block, the tirzepatide. Zepbound is the anti-obesity version of it, and Mounjaro is the anti-diabetes version of it. Also an injectable GLP-1 once a week. And great results for patients. So really the main things that we use is the Qsymia, the Contrave right here, Wegovy, and the Zepbound. And then really like the mechanisms of actions, we briefly talked about it, right? So the orlistat is really gastric and pancreatic lipase inhibitor. So you can imagine what it does. Any
Sometimes it's hard to
questions?
keep up with these medication, but when I look at the graph before, like it's
Yeah.
a lot of medication turning red as we're going to blue. So it's I'm not sure if
Yes,
the
yes.
side effect is this a side effect that we didn't catch up on and we're waiting. It's
We
something
don't
kind
know.
of to consider.
Yeah, right. Yeah, so like here, the sibutramine started in 1997 and discontinued in 2011. Non-fatal MI, strokes, and other side effects. Like, you guys can comment on those from a cardiac standpoint. Do you guys have those in history of cardiac issues?
Nothing cardiac issues with pulmonary hypertension. Others kind
Yeah,
of, yeah, but I
yeah,
can't remember or recall any of these side effects.
yeah. Yeah, some of them are like, majority of them are like amphetamine in nature, and then of course the fen part. That was like the biggest thing, the biggest news, right? So it was a big deal for many
Yeah.
years. So again, we talked about like their mechanism of action, and a lot of them work well if they're used for the right patient, right? So not all medicines work for everyone. And it's that's where the history and the evaluation and the trial and error comes in place. Mostly knowing the patient's history and what's going on with them leads us to deciding what is the best medicine for them. And then, of course, like anti-obesity medicines and heart health, basically, if a person loses weight and they loses the excess fat mass, inflammatory conditions, insulin resistance, all will improve. And as cardiologists, I'm sure you see that all the time. And knowing that as soon as inflammation gets better, insulin resistance gets better, a lot of the vasculopathy will improve as well. So those are like some of the things that we focus on. Yes, heart health, anti-obesity medicines, of course, the Wegovy semaglutide, and now it's FDA approved for coronary artery disease with obesity.
Yeah.
So it's huge that I think Medicare has approved it for that.
Yeah.
And then obstructive sleep apnea is treated now with tirzepatide, which is Zepbound. It's FDA approved for that.
Well, that's what I was, and tirzepatide also, the first episode of The Heart of the Matter was about the Summit trial, which is about tirzepatide, right? And how it actually improved some outcomes in HFpEF. So I'm curious to see how it will, continue to show up here too. You're going to see it more because you're going to see your patients kind of more longitudinally that have these other comorbidities. So I think you'll see it definitely before everybody else does too.
Yeah. We'll keep them away from your clinic. You guys are already busy enough.
Yeah.
Like I think the wait time, if someone wants to go to a cardiologist, is like easy 3, 4, 5 months.
Oh, really? Really? I see them same. I see them same day or next day. We're pretty open.
Well,
we have a system in place, I should say.
Maybe because you're like highly specialized, but for general cardiology in the private practice here, it's
yeah.
I think your patient clientele, the ones that end up seeing you, have already seen like 2 other cardiologists and then ended up with you. So maybe that's why.
Which is not
they
good
also
news
get
at
a
all.
fast pass coming straight from the hospital.
Yes, that too.
When they get admitted to the hospital and then they come and see their cardiologist out, they get seen a little faster, but hopefully,
that's right. That's right.
Yeah. And then, and of course, we have to talk about bariatric surgery. We talked about when we send patients to bariatric surgery. So you've got the sleeve gastrectomy, Roux-en-Y, the biliary pancreatic diversion with duodenal switch, and then, of course, the gastric band. And those would come with their challenges themselves. Patients would lose weight, hopefully the majority of them in a nice way. And what we hope for is that they don't gain some weight back. that is the toughest challenge, because somehow, some way, the body will get adjusted to what's going on in their body, and some of them may end up gaining more weight.
Right.
Yeah. And then,
so what is the bottom line, Dr. Rifai?
Bottom line, this is something I saw really from a patient asking like what they wish their healthcare provider knew or considered, right? So they wanted to say, okay, well, weigh the patient all the time. If they don't want to be weighed, don't make them get weighed. Make sure that you've got a chair that's wide enough for them to sit in a clinic, that they have chairs that have armrests, proper blood pressure cuffs. And, everybody should be treated with respect, and make sure that the scale, don't have a scale that the weight limit is like 270 pounds, because they could be 300 pounds, right? And always give the patients encouragement, even if they lost 2 pounds, even if they lost 3 pounds, because the million-mile trip starts with a step, right? So really kind of encourage the patients and support them in their journey. And then for the bottom line, always remember, it is a complicated disease. It is a chronic disease. It is multifactorial. And most important, it's a relapsing disease. As soon as the patient loses weight, they really have to keep the treatment going, no matter what the treatment is, because again, it's dietary modifications, physical activity, behavior modifications, medications, and then surgery. Those are like the 5 things that we do when treating patients. So the first 2 steps, the dietary modifications and the physical activity and the behavior modifications, have to be installed in the patient's life all the time, no matter what. Because if they were on the medicine, as soon as they stop the medicine, guess what? They will gain the weight back if their other habits are not really solid. And then as soon as any of you guys or any of other colleagues feel that the patient does have a weight challenge, immediately refer them to an obesity specialized clinic that could support them in their journey. And don't wait too long.
Right. Well, Dr. Rifai, really, it's a very enlightening number one specialty. I mean, as you mentioned, the weight loss of Michigan has been specialized in this for many years. It's a pandemic. Yes. It's a pandemic problem. It's all over, not just in Michigan and outside. And as we mentioned earlier, this is an upstream problem. To prevent a major problem, awareness is key, and to be aware of these solutions at the beginning and kind of implement them and use them early on to prevent. I really enjoy the slides and enjoy the conversation. I have to do that ratio now again. My waist I'm low, less than 40, which is good, but I have to do the other numbers now when we hang up to make sure I'm within the appropriate range. Really appreciate your time and expertise, and hopefully we get to see you in different episodes in the coming future.
Yeah, I would like to invite you, Dr. Alraies, both you and Dr. Pareddy, to come and visit us, and we'll do an in-body testing on you, and we'll see where the challenges might be.
We would love to. We would love to.
Absolutely.
I mean, and the thing is, it's just like you said, right? Like, how can we refer and how can we do this? Dr. Alraies mentioned this too. If, we aren't aware of all of the things that you're doing, right? To be knowledgeable about what you're doing, we're able to refer our patients appropriately, and say, hey, this is what it would kind of look like. But I really think this person is a great fit for you. And I feel like you would be a great fit for a lot of our patients. And I think that this is very important for us, even moving forward.
Yes. Yeah, thank you both.
Thank you so much for coming.
Thank you,
we really appreciate having you.
All right.
I will see you next time. And for all the viewers, thanks for watching us. This is a Heart of the Matter episode coming to you next month, but this time with Dr. Rifai. Thank you so much again, and have a good night.
Thank you. Bye.
All right.